time, I would like to introduce you to today's speaker. Marty Ross serves as a trusted advisor to providers navigating the ever-expanding maze of healthcare regulations. Her deep and wide understanding of new payment and delivery systems and public payer initiatives is an invaluable resource for providers seeking to strategically position their organizations for the future. Now I will turn it over to Marty.
Great. Thank you, Kim, and hello, everyone, and happy Friday. Working towards the weekend, but let's take an hour here now and talk about observations on the commercial payer contracting world and how we're beginning to see shifts in that market and how you can best position your organization moving forward in light of these changes. So specifically, our agenda today, we're going to talk about the pressures that commercial payers are experiencing with regard to the continuation of their traditional fee-for-service contracting models. We're then going to take a closer look at what commercial payers are doing around value-based purchasing initiatives and what we can expect to see in the future in that regard. Then we're going to get a little more practical and talk about some considerations for reviewing proposed contracts received from commercial payers. And we're going to focus specifically on 8 key non-price contract terms and give you some practical advice about evaluating those terms and the potential impact they have on your relationships with payers. Then our discussion moves from non-price terms to price terms and what the opportunities are to leverage population through networking with other providers to negotiate with payers from a position of strength. And finally, we'll wrap up with a brief discussion of direct contracting, meaning rather than contracting with the insurance company, to go directly to employers and contract with them to provide services, sort of cutting out the middleman, so to speak. So with that overview, let's get started with just an orientation to the changing market. And for those of you that participated on Wednesday in our call regarding physician contracting, this is sort of a quick review for you. But you can appreciate that we are now at the beginning of a decade-long transition from a system based on fee-for-service reimbursement or volume reimbursement to value-based reimbursement, where the orientation goes from delivering services to ensuring the health of a particular population. And that transition from volume to value really focuses on moving the needle in 3 areas: improving the patient experience of care, improving overall population health, moving the metrics, and also reducing costs of delivering care more efficiently. And this is often referred to as the triple aim, which has been a key focus for CMS and government payer programs. But now the commercial payers also see the importance of this transition and how they can support these efforts through their own contracting strategies. Again, remember, we go from a system of sick care to a focus on overall population health as we move towards value. We go from an orientation around diagnosing and treating a patient with a particular illness or injury to one where the healthcare system needs to address the preventative as well as the chronic care needs of their population. And importantly, this new orientation moves from a system where risk resides with a payer to one where risk resides with a provider. And that in turn requires providers to be developing competencies on how to effectively and appropriately manage population health. Unlike payers, providers actually have the competencies to move that population health and thus be able to assume the risk moving forward. And again, you're not going to wake up tomorrow with all capitated commercial contracts. We are again in a transition period, but we need to be ahead of the curve in developing that skill set through our contracting negotiations. So we moved in from a very traditional fee schedule model where a payer offers a fee schedule and the room and opportunity for negotiation is the rates on those schedules, depending on the importance of that provider to the payer in delivering adequate coverage to their population. And then also the ability of that provider to come to market with a strength, numbers that cannot be ignored. And so typically we appreciate that the larger integrated delivery systems are in a better position to negotiate against a commercial payer to get higher rates. And that's usually been the orientation around commercial contracting, is how good a rates can you get because of your importance to the market or the size in the market. But now with new population health models, we move away from just a focused negotiation on fee schedule rates, that we start having conversations around narrow networks and tiered benefit plans. And so payers starting to build networks based on different factors and how they introduce that network to a tiered benefit plans, and we'll drill down a bit on that in just a minute. We're also seeing enhanced fee schedules where it's not just your negotiating strength that makes a difference, but a provider's willingness and ability to deliver care management services to help provide more efficient care. And then now in the commercial market, you're beginning to see movement towards pay for performance. So it is not just a flat fee schedule rate, but there's graduations in the fee schedule and additional bonus payments made by the performance of certain metrics by the provider community. And then the more elegant programs like the shared savings programs, bundled payments, centers of excellence, and global budgets, you're beginning to see movement in the commercial community, commercial payer community toward these as well. We know that CMS is very committed with the government programs to moving away from traditional fee-for-service, DRG, APC, acronym of the day, type of reimbursement models to these alternative arrangements. And as Secretary Burwell announced in January of this year, that HHS is committed to having 90% of all Medicare payments tied to some sort of quality metric, some value metric by 2018, a mere 3 years from today. But also then, to complement that value orientation, CMS is also committed to moving providers into these alternative payment models, such as bundled payments or shared savings programs or centers of excellence models, and achieving a 50% provider participation in those types of models by 2018. So these are the goals set forth at the federal level. The question then is, how is this also impacting on the commercial side? Well, we know that commercials have been very interested in tiered pricing. So this starts the conversation around narrow networks. And I know I've had many conversations with rural providers that have been very concerned that they won't have a place at the table as the larger systems become more aggressive in pursuing narrow networks, that they think they could even be cut out of many of those contracts. Now, the real experience in drawing narrow networks has been that the payer community has encountered significant resistance from the employers with which they contract when they attempt to introduce narrow restrictive networks. So when a payer goes to market and says, we have a network that only includes these providers, that there's often pushback from the employers who are actually purchasing the product from the commercial payer, because their employees, their covered lives within their employee health plan are very, very much want to remain and have options to see a wide range of providers. So other than narrow networks which exclude certain providers, you're seeing commercial payers more interested in tiered pricing. And so they develop networks that are rewarded by having certain better pricing involved. And so if you are identified as a Tier 1 network, as a member of a Tier 1 network, you're going to receive a higher reimbursement from the commercial payers as opposed to being a Tier 2 or potentially even a Tier 3 provider, which means lower reimbursement. Now, by using this tiering system as opposed to just a strict narrow network system, the commercial payers believe they can avoid this criticism that they're cutting providers and thus employee options out of the equation. And when you start talking with commercial payers about their strategies, you see that this becomes very important to them. So here you have some data from a study done last year by McKesson Health Solutions, kind of a broad-ranging survey of payer strategies. And you see that tiered pricing is already in the toolkit of 68% of commercial providers, that they're using that as at least part of their current strategies, these tiered network strategies. And then even those that are not using that strategy today are very interested in pursuing that strategy within the next 2 to 3 years, to the point that you can expect 80% of commercial insurers, commercial plans, will have some component of tiering in their fee-for-service pricing. To sort of, if it is just the beginning again of that transition away from traditional fee schedule orientation, where it's might and power in the negotiation process, to one where we place you in tiers based on different metrics. And those metrics are far. It may be a metric that's based on your ability to negotiate with a commercial payer, but also on your market penetration, the essential services you provide for a particular population, but also your performance metrics. So all of this pushes toward the beginning of real change within the commercial payer structure on how they develop networks and how they reward providers. The other trend which you see in commercial payers is providing fee-for-service reimbursement for care management services. And these particular contracts are very tied toward patient-centered medical home initiatives. So, for example, Blue Cross Blue Shield of Illinois, Blue Cross Blue Shield Care First in the D.C. area, both have initiated sort of intensive medical home programs where they provide incentive payments to primary care physicians to develop competencies in patient-centered medical home principles. And those rewards, in part, include fee-for-service care management payments. And so as historically, the physician fee schedules have rewarded and paid for those activities that either occur in the four walls of the exam room, the four walls of the hospital room, the four walls of the surgical suite, but not the coordination that's involved to move the patient through a continuum of care. But that's always been assumed. That's just part of what that other reimbursement includes. But now there begins to be an appreciation that care management is a real and important discipline. It delivers true value to both the patient as well as the payer, and that we need to treat it as a professional service and reimburse it accordingly. And so commercial payers now are exploring the opportunities to incentivize the movement towards care management through different types of programs. Now that all was occurring in advance of Medicare's decision to begin paying for chronic care management starting January 1 of this year. And if you're familiar with the Medicare program, it is approximately $40 a month reimbursement per beneficiary per month to provide certain care management services to individuals, Medicare beneficiaries, with 2 or more chronic conditions. And the regulatory requirements are spelled out in terms of the practice competencies to deliver that service, who can deliver those services, what the nature of those services are. And it'll be interesting to watch here in the next few months, really, how quickly commercial payers are willing to follow that lead and reimburse for those same services around the same model. You're all very well familiar with the fact that Medicare tends to be on the forefront with commercial payers following. So where we see ourselves today with care management is a few payers led the charge. They were the pioneers in developing these care management, patient-centered medical home programs. You see Medicare then kind of normalizing care management services by providing reimbursement across a very large population. 68% of Medicare beneficiaries have 2 or more chronic conditions. And now the question is, will the rest of commercial insurers follow suit and begin providing reimbursement for these care management services on a fee-for-service basis? And Medicare's view, these fee-for-service payments for care management are really a key part of that transition from volume to value. You're paying on a volume-based orientation, but the service is one that develops competencies that are actually absolutely critical in a value-based reimbursement population health management world. And so strong interest by CMS to incentivize these care management programs, and expected that commercial programs will follow suit. The hitch, the concern, the issue is the common population served by the commercial payers, because commercial payers constantly have to deal with the fact that they don't cover the same lives year to year, because employers will move their group health plan from Aetna over to Blue Cross over to another different commercial payer. So you may have change in movement in that market every year, every 2 years or so. And so historically, that's been a disincentive for commercial payers to make investments in programs such as these care management programs, because they don't have ongoing responsibility for the same population. They don't have the ongoing interest in managing the cost of care for those patients. So you're also seeing that switch in orientation now, as commercial payers now want to maintain employers for the long term. They want to have those relationships and compete on something other than just price, and thus being able to offer these types of services through their plans. It's certainly not happening overnight. It's not a seismic shift. It's more of an incremental change you begin to see in the market now. Then there's the story of what are commercial payers doing with value-based payment models. So we've talked about networking and tiering networking. We've talked about care management fees. And now what's the interest in the commercial market around value-based payment models? And this is providing some alternative to traditional fee-service reimbursement. So here again, back to the McKesson study, you see today that most insurers are still committed to the fee-for-service model, but they are certainly exploring capitation as well as pay-for-performance models, and then to a lesser extent looking at episode of care and bundled payments, global payments, shared savings models. So again, heavy emphasis on fee-for-service, but the other half of that equation, 44% of what's going on in the market today are around sort of these alternative payment models. You see in 2 years, the shift begins towards a higher percentage moving into pay-for-performance orientation. So you go from 10 to 14% in 2 years. Within 5 years, you see that pay-for-performance at 18%. So some growth in capitation, but also a significant growth in pay-for-performance models, so that value-based model, but also increasing interest in the alternative payment models like bundled payments, like global payments and shared savings. So the payers expect to be moving toward these other models within a very relatively short period of time, 5 years. And granted, this data is already a year old, so view that more as to where they see themselves in 2018, 2019, offering a different range of opportunities for providers, different types of payment arrangements. So when we talk, and let's really focus in on this pay for performance, where we expect to see almost a 10% increase within the next 4 years in the commercial payer community. And what will those models look like for pay for performance? Well, what we likely anticipate, as is often the case, commercial payers will piggyback on what Medicare is now currently putting in place. And so they can mimic these programs, they can mimic the data that CMS uses to operate these programs and begin introducing similar types of incentives as well as penalties into the program. So on the hospital side of the house, there are 3 key Medicare programs now in place for PPS hospitals. And first, since 2013, we've had the readmission penalties. So hospitals that have a high incidence of readmissions for certain episodes of care experience a decrease in their reimbursement across all episodes of care. And so definite incentive for hospitals now to be carefully watching their readmissions and looking for ways to keep patients in their home and doing well after a discharge. You also have, beginning last year in 2014, the value-based payments. And here, CMS looks at a range of metrics, including quality and efficiency, and scores each hospital on those metrics, and then compares hospital scores. And those hospitals that find their performance above the mean have an opportunity to earn additional payments, while those hospitals below the mean are penalized and see their payments reduced, sort of a reallocation of monies between hospitals based on their performance on those value metrics. And then introduced this year, where the HAC and never event penalties. HAC is hospital-acquired condition. Never events are the surgery on the wrong limb type of episodes. And what we have here is Medicare imposing a penalty on the 25% of hospitals with the highest scores on HAC and never events. This is one of those instances where you don't want to be in the top quartile because those are the ones that are being penalized. And so there's movement within those programs. Now, what we can anticipate commercial payers doing is looking at this data that's available and, again, echoing the Medicare program, either using their own data, so looking at their own experience with hospital readmissions, or simply relying on the Medicare data and using that Medicare data as the benchmark on which they're going to make their own decisions as they implement similar types of programs. Haven't seen a lot of this yet. Haven't seen a lot of renegotiation on hospital contracts that include these elements, but as these programs mature over the next couple of years through the Medicare program, we can anticipate commercials following the lead. Then let's move over to the physician world and Medicare pay-for-performance programs there. Now, the 2 primary programs are the Physician Quality Reporting System penalties. So physicians are required to report certain quality information to CMS, and their failure to do that reporting automatically costs them a 2% reduction in their Medicare physician fee schedule rates. And that, again, that's just been going online now in the last year. And then also CMS is introducing and phasing in over the next 3 years the value modifier program, similar to the hospital value-based payments model. But here, Medicare compares physician practices based on their scores on certain quality measures as well as efficiency measures. And again, identify the mean and look for those physician practices that are high quality, low cost versus those physician practices that are low quality, high cost, and seeing adjustments in their physician fee schedule payments to the tune of a -4 up to a +4 and even higher based on where you land in that value modifier um, scheme. And while it's starting small, this program today in 2015 only impacts very large practices, those with more than 100 eligible professionals. Next year, that number goes down to practices with 10 or more eligible professionals. And then by 2017, all physicians, the solo practitioners, as well as those in group practices, will be subject to this value modifier. Again, the question is, how do commercials follow suit? Well, they simply use provider scores on these value modifier programs to make their own decisions on how they'll reward physicians in their plans. Now, what's new in the mix, and will be very interesting, is MIPS. And MIPS is part of the Medicare Access and CHIP Reauthorization Act, or MACRA as we now call it, which was the legislation passed just this month and signed by the President that ends the sustainable growth rate formula for calculating the Medicare physician fee schedule and replaces it with a new system for calculating those rates. But that legislation, MACRA, also implements by 2019 a new system of value-based payments for physicians. And this MIPS program, the Medicare Incentive Payment System, or MIPS, scores physicians based on quality metrics, efficiency metrics, meaningful use of an electronic health record, and clinical quality improvement activities. And so those 4 domains, scores on those 4 domains translate into a numeric score between 1 and 100. And the physician practice then is assigned a particular number, say 82, 76, 100%. And again, back to this idea of a mean, they set the mean, and those physician practices above the mean, eligible for bonus payments. Those below the mean are going to see penalties. And again, that range under MIPS program, when it's fully implemented by 2023, that range is 12% on either side of that equation. So you can see a 12% bonus payment, a 12% negative rating. But more importantly, you're now talking about physicians being assigned an objective number and being able to rate physicians in the same way, say, you rate restaurants and having a star system. So it's going to have significant impact on how commercial payers start looking at providers and how they reward them or enter into fee schedule arrangements with them. So be aware of these programs coming online on the Medicare side of the equation and how they're going to potentially impact how we negotiate with the commercial payers. So shifting gears now to where we see commercial payers going in terms of away from the traditional fee schedule model, let's stop and put price aside for a few minutes. And let's talk about some key non-price contract terms. And I'm sure all of you have experienced the frustration of being presented with a 100-page document by one of the key commercial payers in your market and being told where to sign and the date by which the signed contract needs to be returned. And really not having the experience of how to evaluate that contract and where to see where the potential traps and pitfalls are and how that could put your organization in a corner. And it may not just be a matter of negotiating new terms with the payer, but at least appreciating what's in that contract and what you're committing to and how you can manage the risk presented by those contracts within your organization. So we've identified really 8 key contract terms that we always look at when we're reviewing commercial payer contracts. And again, to appreciate what we're getting into, and to the extent that it's possible, negotiate some of those terms with the commercial payers. I appreciate that commercial contracts are very difficult to negotiate because payers don't want to get off their standard forms. They don't want to deviate from the usual. But still, there are sometimes opportunities to negotiate these terms with payers. But it is just the need to appreciate what you're getting into, eyes wide open with a particular payer. So let's go through each of these 8, and I'll kind of talk about where the concerns are, what you should be looking for. And number 1 are timely filing requirements. commercial payers will deny claims that are filed outside the timely filing requirements. So that timely filing requirement is a year. If you file that claim at a year and 1 day, that alone is the basis for the commercial payer to deny any payment. And the reason commercial payers are particularly concerned about that is that churn that I referenced previously, that an employer will go from one plan to another, year after year, looking for the better package. And so it is essential to commercial payers that they get all the claims in and get them processed and paid so that they can close the books on a contract that they no longer have because that employer has moved on to a different commercial insurance plan. And so they are very strict, typically, in their enforcement of timely filing rules. So be aware of those particular requirements in the contract. Make sure that your billing office appreciates the importance of those deadlines. And that even your providers are aware of that, so they're getting their documentation in on time and thus allowing the claim to be dropped in a timely manner. Also be concerned about the definition of the exceptions and extensions to the timely filing requirements. Oftentimes, I mean, you have trouble filing a claim because you're just not aware that the patient has a certain type of insurance, particularly when you get into secondary insurance claims. And so make sure that you have allowances in those contracts that take into account those situations. When you are truly without blame in the delay in filing the claim with the insurance company, that those situations are accounted for in the terms of the contract. Because otherwise, these are indefensible denials. You don't have the opportunity to complain to the insurance company, hey, you got us on a technicality, and you should reconsider our claim. Usually when it's a timely filing issue and you're not within one of the contract exceptions or extensions, you're going to have a little room to stand on, and you're going to have provided the service and not been able to receive any reimbursement for it. Second provision about which you should be concerned are prompt payment requirements. The insurance companies can literally make thousands of dollars by holding payment on claims for a few days because they can continue to earn the interest payments on dollars they hold. Once the insurance company pays your claim, it no longer has those dollars. It no longer can use them for investment purposes. And so insurance companies have every incentive to delay payment on claims. And thus, most states have prompt payment laws that require insurance companies to pay claims within a certain time period of their receipt of the claim. So they have to have processes to make sure that, have a claims process in place that meets the prompt payment requirements. So typically it's from the day that the claim is received, you have 10 days to get payment out the door or 30 days to get payment out the door. The trick is, when is a claim received? And what commercial and payers will argue is that the claim wasn't a clean claim. We didn't have all of the information presented by the provider necessary to process the claim. So some information was missing or some information was inaccurate on the claim received by the insurance company, and until that information is supplied, we can withhold payment. And so it is important as you review commercial insurance contracts to look at what is the definition of a clean claim. What information has to be included on the claim form for that insurance company upon receipt of the claim to be subject to the prompt payment requirements. And oftentimes, commercial insurance companies will be very, very particular on how they interpret the definition of clean claims. And so even the slightest information missing or information being placed on the wrong part of the claim form, any of that can lead to payment being withheld on clean claims. Again, on the process side within your organization, making sure that your billing folks are aware of the definitions of clean claim, that you have scrubbing processes within the process so that you're identifying potentially unclean claims and getting them rectified before they ever go to the payer and are ready to go. Next provision I want you to pay attention to in these commercial contracts are those with regard to amendments. And typically there will be a provision in commercial payer contracts that say, we, the insurance company, can amend the terms of this contract by sending you, the provider, notice. And if you as the provider do not object upon receipt of the notice, we will deem that you have accepted this amendment. Now, these amendments often impact the fee schedule. And so there'll be changes to the fee schedule, either adding coverage, reducing coverage, changing rates, whatever it may be. The insurance company's vehicle for accomplishing that is by sending you notice to amend the contract, to amend the fee schedule. And then if you do not raise an objection, that amendment then becomes incorporated into the contract. And there are then within the commercial contract, what happens if you do raise an objection? What's the process to be followed? And in some cases, the only option you have is to terminate the agreement if you disagree with the amendment. And so you can appreciate how the commercial payers can utilize these amendment provisions to, shall we say, engage in some mischief in terms of the payment made under the commercial insurance contract. And so be aware of how the amendment process works, to what provisions does it extend, specifically how does it impact the fee schedule, and have, again, a process in place in the organization so that receipt of those proposed amendments are acted upon appropriately, and you're communicating with the commercial insurance company there. Fourth provision we need to take a look at in these commercial contracts are the termination provisions, and specifically the without cause termination. Commercial insurance companies tend to lock down providers for a long period of time, so you are allowed a fairly narrow window of opportunity to terminate the agreement. Sometimes you'll see 60 to 90 days before the renewal date, you have a window of opportunity to terminate the agreement or continue under that coverage. And so they want to make sure that they have stability within their network, stability within their rates, and so they certainly want to restrict providers' abilities to get out of the contract, to renegotiate the contract. They don't necessarily return the courtesy on the other side of the equation, because typically insurance companies will push to have a without cause termination right. And so they can provide notice to you and terminate the contract once upon expiration of that notice period. The problem there is this without cause termination becomes a pretty nifty tool to extract concessions from providers. So you may find yourself in receipt of a without cause termination and then being offered a contract with less favorable terms. And so you don't enjoy the benefit of your bargain for the full time period of the contract. And so this is a provision to watch carefully. What does the insurance company have to do? What can they do to terminate the contract? So let's move on now to the next set of non-price contract terms. The fifth one to pay attention to regards eligibility and pre-authorization. And so what is the process the insurance company provides to identify whether a particular patient is in fact eligible for coverage? And closely related to that is what is the process for pre-authorization of services? So when do you have to obtain pre-authorization in advance of providing the service in order to be paid for the service? Make sure you understand the methods and your staff utilizes those methods for determining eligibility and pre-authorization. Also focus in on the time frame for the insurance company to respond. Oftentimes they leave you in a lurch because they've afforded themselves, 24 or 48 hours or even longer to respond on a request for an eligibility determination or a pre-authorization request. And that obviously interferes with your ability to provide timely, appropriate patient care. And so make sure that those time frames are realistic and don't place you in a position of having to make a choice between providing appropriate care and getting paid. You should never be in that sort of catch-22 due to their time frames for responding to your requests. Also look for provisions, the no-fault provisions to protect yourselves. And again, many states have moved to require by statute these provisions be included into insurance companies, albeit they are not universal. Not all states have adopted these provisions, but that there should certainly be specific circumstances in which providers still can receive payment despite the fact they did not get a prior eligibility or pre-authorization approval from the insurance company. So look on how that is spelled out in the proposed commercial insurance contract. Number 6 concerns the provider manual. Oftentimes, I referred previously to the 100-page contract, but sometimes you only get like a 5-page contract, and in there you'll see references to the provider manual. So in addition to any terms and conditions of this contract, you, the provider, are also subject to the terms and conditions of the provider manual, and we reserve the right to revise or reissue the provider manual at any time. So what they've done is taken what are typically terms in the commercial insurance contract and moved them into this kind of more loosey-goosey provider manual that can be changed much easier. That provider manual also tends to have pretty inexact language in it that the insurance companies tend to interpret to their advantage and benefit. And so when you see these contracts that make reference to provider manuals, be sure there's a process for you to get the most current version of the provider manual. And importantly, what's the process for seeking clarification if there is ambiguity in the provider manual? And then third, what is the process for amending the provider manual? Is it the same that you get an opportunity to review and object to the revision in advance of it going into effect? Seventh, we want to look at the credentialing process. When you bring new providers into your organization, what is the process to credential them with the insurance company? Are you allowed to have retrospective credentialing so that if it takes 2 months to get through the insurance company's process to credential a provider, are you completely prohibited from obtaining any reimbursement for services provided by that, furnished by that provider prior to the credentialing being finalized? Or does the insurance company allow a look back so that you can submit those claims after the fact? These provisions tend to vary significantly between insurance companies. Some use credentialing as an absolute starting point, that you cannot submit any claim for a service furnished by a non-credentialed provider, and thus they will not look back or take retrospective submission of claims. So be attentive to that because it will impact your staffing decisions. So if you bring in a new ER doctor and they haven't yet been credentialed with the insurance company, you may have to look for workarounds that they're not providing services for that particular those particular patients that are insured by that insurance company for a period of time. Finally, and certainly not last or least, is the grievance procedures. What process has the insurance company established for internal grievance? Oftentimes, these are provisions that you have to exhaust before pursuing any other remedy. So prior to making a complaint with the insurance commission or prior to filing a lawsuit or anything of that nature, the insurance contract says you first have to go through our internal grievance procedures. Now, if that's the case, you need to be sure you understand those procedures and that there are appropriate time frames around those procedures, that you should not be unfairly penalized by having to go through a grievance procedure that literally takes months to resolve. And so take a careful look at those grievance procedures as they're spelled out in the commercial contracts. So there's the big 10, the ones you want to be sure to look at. There are certainly others as you review commercial contracts, but these are the ones that are going to impact how you perform under that commercial contract on a going forward basis. Well, let's go back then to a conversation around the price terms. Since These tend to be contracts you don't have a lot of room to negotiate on non-price terms, and because the price terms directly and significantly impact your operations, how do we effectively negotiate on price, particularly as rural providers, because we don't have that leverage with the commercial payers, and we don't have oftentimes folks that are well trained and experienced in negotiating with the commercial payers, and we often find ourselves at risk of being excluded from narrow networks, or at least not having that opportunity to participate in the upper level tiers. And this really raises the question, can we negotiate together? Is there an opportunity for multiple rural providers to present themselves to commercial payers as a network and say, don't negotiate with us as individuals, but let's take our power and unite ourselves as a network and go and negotiate with the payer now that we have a larger population recovering, we have a bigger provider base that becomes more essential for the commercial payer to have that provider base available to the covered lives. And so it is, and then we have more sophistication that if we bring our resources together as 3 or 4 or 5 facilities covering 3 or 4 or 5 communities, we then have an opportunity to bring someone on board with more skills in negotiations and interpretation of these contracts that really can better represent our interests. And so we want those opportunities for network contracting. Well, we have 4 options for network contracting we want to cover here. Single signature contracts, messenger model, supported negotiations, and then what we call centralized support. Single signature contracts are just what they say they are. It is the network that actually signs the agreement, and it is the network that is accountable to the insurance company for performance under that contract. And the key relationship then is the network and its participants. And so these are governed by participation agreements. And so each of the providers who are part of the network sign a participation agreement with the network on how they will perform, what rules they will be subject to, how they will be covered under the commercial insurance contract between the payer and the network. It is certainly optimal getting to single signature contracts. The obstacle, of course, are the antitrust laws. Because our federal and many state antitrust laws prohibit us from jointly negotiating price terms if we are independent economic entities. So while the large integrated delivery system as one economic entity can go negotiate price terms with the payer, those of us that remain as independent economic entities, all with our own taxpayer identification number, the antitrust laws say from the get-go, it is per se illegal for you to jointly agree to price and negotiate on price. So what do we do about that? Is that dealing with that obstacle to network contracting? Well, first of all, if the payer doesn't object and waive the antitrust concerns, then we are good to move forward. And oftentimes, particularly with rural providers, some insurance companies will say, you know, it's just a lot easier for us to deal with one network rather than negotiating with 5 or 10 or 15 individual facilities. And so we will agree to negotiate on a network level with you. And I would guess we're going to see more of this moving forward when as the insurance companies look for pay-for-performance contracts. They don't want to necessarily negotiate that on a one-off, but they would rather be negotiating for a quality of care with a with a network, knowing that that network would also have an interest in enforcing those quality and efficiency standards. And so they become partners with the insurance company in delivering that better product. But if the payer should object, or if you don't, really it's a matter of an affirmative agreement by the payer to deal with the network. But if the payer objects, there is still the opportunity to pursue single signature contract if the network is able to demonstrate a sufficient level of clinical or financial integration. And these rules stem from guidance provided by the Federal Trade Commission, which is the agency with primary responsibility for enforcing the antitrust laws. But the FTC has said when a network of providers integrates, either economically or clinically, their ability to negotiate with a payer as a single signature network actually is pro-competitive because they're bringing higher quality care, more efficient care to the network through the market, through the network. And so it's a good thing that they negotiate together. Now that then leads the question of what is clinical integration, what is financial integration? Well, the easy question on financial integration is that you have a shared financial risk. You have a capitation or you have a pay-for-performance risk that is shared across the network. So if network member A performs badly, that impacts network member B and network member C and network member D. So they share that economic risk of performance. Now, that's a hard one to sell, right? That you don't necessarily want to be at risk with your neighbor in an economic arrangement like that. So the alternative is clinical integration. And what the FTC has told us over the years about clinical integration is that when you have a network of providers that develop and enforce shared protocols, so they have clinical guidelines they follow, and they also assume the responsibility for care coordination for a population, they are become a clinically integrated network. Now, these are concepts that came out in the 90s when the FTC was developing this guidance, but you see that this clinical integration concept is directly relevant to what's going on now in population health and value-based reimbursement, that those are exactly the behaviors that and the competencies we need to develop. And so this becomes now sort of the double reward for network participation, that you have the opportunity for single signature contracting, but also simply having the capacity to do single signature contracting, having clinical integration is actually then allowing you to perform very well under these contracts because you have those competencies in place. Now, if we're not going to have economic or clinical integration, there are still advantages to the network, that they do allow for some coordinated negotiations, and that would typically be the messenger model, where the network negotiates directly with the payer but brings those terms back to its network members to accept or reject. And so that network serves as a messenger and sort of cleanses price negotiations because they are an economically independent party. And so there is not collusion or coordination on the price terms among the competitors. And so the messenger model, while certainly beneficial to its participants, can be somewhat unwieldy to administer. And if you go down the route as a network using the messenger model, you want to be sure you're getting good advice, that you have processes set up appropriately to enjoy the protections and eliminate the risk under the antitrust rules. So a third model that networks can use are supported negotiations, so that the network works together to develop sort of standard terms that they find acceptable. And they also review contracts and provide explanation of contract terms. They really are providing a service to support its network members in evaluating contracts and negotiating contracts. But at the end of the day, it is up to each of the individual providers to directly negotiate and sign their contract with the payer. So think of it as this kind of a learning collaborative created by a network, and we're going to learn and act around how we negotiate our commercial payers. The network is never a party to the contract, and always the individual providers are responsible for their performance. Finally, you're seeing some trend towards centralized support services, and where we're really seeing this happen is on Medicaid MCO contracts. And so the Medicaid MCOs will work with a network and provide through the network funds to support care management and care coordination activities through the network. So rather than having just full single signature contracts or completely independent contracts, the payer will negotiate and contract with the network to provide a certain range of services. So rather than every provider furnishing all the services, there are certain services carved out and put into the network contract. And typically, again, these are preventative care services or care coordination, and then the network members share in the responsibility to provide those services, but also the revenue coming in or the support revenue that's coming in through the network. And so kind of a cool common kind of a cool approach to providing the right level of services and being able to leverage size. And so you'll see community health centers are often in these types of centralized support arrangements on a Medicaid MCO type of contract. Finally, and just briefly, let's close out here by raising this issue of direct contracting. And for rural providers in particular, this is an interesting opportunity because your communities tend to be dominated by one or two employers. And oftentimes, one of those employers is the school district, which is typically the largest employer in many of the rural communities, or maybe the hospital itself as a significant employer. And so where are the opportunities for these contract arrangements? First, look at your self-insured employee health plan. Can you use that as a training ground for clinical integration, that you create your own network of providers to perform and provide services for your covered lives? It allows you to introduce pay for performance payments or shared savings arrangements or even create a narrow network. And so many providers are pursuing their employee health plan as sort of that first step in learning to align with providers in delivering services. And then finally, there's the option of other employer self-help plans. And these can be arranged, not necessarily taking the entire risk on, but saying, we will provide wellness and prevention services for you directly. You can carve those out of your insurance contract. So rather than paying Blue Cross Blue Shield to do that, we will, as a network or as your provider, deliver those core services. And that we believe we can do it at a lower cost, and we also can prevent your long-term costs by appropriately and effectively intervening. But then you can also get into more robust types of arrangements with other employers, either through a global budget or a shared savings arrangement. And again, there is just beginning to be movement in the market on these particular areas. So again, a pretty broad overview of what's going on in the commercial market. It's certainly a time to be eyes wide open, paying attention to trends, looking for opportunities. Rural providers definitely need to have their seat at the table because you provide a critical range of services to these populations, these covered lives, and being able to negotiate either because of you being familiar with contract terms, but also being able potentially to utilize a network arrangement to protect you. So Kim, we've got a few minutes here. If folks have some questions, we can see if we can address them.
Thanks, Marty. You've covered so much in these last 2 days. Does anyone have a question for Marty? You can type it in the chat box, or you can press *2 to unmute your line. Well, Marty, I think you covered it.
Okay, well, I'm sure folks actually have questions. It's all kind of been drinking from the fire hose here the last couple of days. And so my contact information has been on the slide decks, and folks want to drop me an email message if they have a question, I'd be more than happy to address that. Or if they want to go through you and kind of share that information across the group, that'd be great too.
Absolutely. Thank you so much, Marty, for a great webinar series this